Okay, so a quick video on respiratory physiology. First, we need to talk about ventilation. Ventilation is all based on that law in physics called Boyle's law, and it's just the inverse relationship of volume to pressure. So ventilation is mechanical, so either expanding the thoracic cage or depressing the thoracic cage. So when we want to have inspiration, the diaphragm contracts, which pushes inferiorly. The external intercostals pull up and out on the ribs, so it opens this thoracic cavity. When the thoracic cavity opens, we are increasing the volume. So when the volume goes up, the pressure goes down. So atmospheric pressure is about 760 millimeters of mercury. So if we suddenly increase the volume of the thoracic cavity, this might drop to something like 758. And if that happens, well, gas is going to move from a high pressure to a low pressure, and gas is going to move into our lungs. Okay, and similarly with expiration, or at least quiet expiration at rest, it's a passive process. So the elastic tissue of the lungs, the elasticity of the thoracic cage just reduces the volume of the thoracic cavity. So diaphragm relaxes, eases up, external intercostals relax, then it's just passive recoil of the thoracic cage and the actual lung tissue. So that happens, the volume goes down. So the volume goes down, well, then this pressure is going to go above atmospheric pressure, and let's say it goes to something like 762. 762. So now, again, it's higher than atmospheric pressure. Well, now air is not going to move in, it's going to move out. And we have expiration. So it's that simple. Obviously, with forced inspiration, there's accessory muscles like the sternocleidomastoid muscles, the scalene muscles, and with forced expiration, there's going to be internal intercostal muscles as well as the abdominal muscles, rectus abdominis, external, internal oblique, and transverse abdominis, helping push the thoracic cavity closed faster. But it's all based on just the volume of the thoracic cavity. Now, the other pressure you think about is right here is intrapleural pressure. So we know the lungs are surrounded by the pleura. The visceral pleura is the layer attached to the lung tissue itself. The parietal pleura is the layer lining the thoracic cavity, so the wall, the chest wall, right? So the ribs and the muscles. And between there, so it's the serous membrane, there's a thin layer of serous fluid, and it keeps those two layers stuck together. And so when the rib cage expands, the lungs go with it. So that has to be a negative pressure, meaning less than atmospheric pressure. There's two conditions. One, pneumothorax, so if there's any kind of penetrating trauma to the chest wall, or it could be spontaneous. But if that pressure in the intrapleural space goes to 160 or normalizes with atmospheric pressure, the lung will not expand. That's a pneumothorax, and you will have a collapsed lung. So that's ventilation. So there's all the graphs with vital capacity, forced, inspiratory capacity, forced expiratory capacity, all that stuff. But I want to look more at this. So this is the difference between a normal spirogram compared to an obstructive lung disease and a restrictive lung disease. So we all know the basic tidal volume, inspiratory capacity, expiratory capacity, and then our vital capacities are tidal volume with the addition of forced inspiratory and forced expiratory capacity. So our FEV1 is our forced expiratory volume at 1 second. So this graph is volumes of air from 0 liters to 5 liters. And this is time on the bottom line, so 0 seconds, 1, 2, 3, 4, and so on seconds. So the FEV1 is the forced expiratory volume in 1 second. So if you're testing someone's ventilation and they take the biggest breath possible, fill their lungs, and then blow it as hard as they can to get all the air out of their lungs. That's what they're doing with this test on this spirogram. So how much air they get on that first second, it should be about 80%, okay? Because we're comparing this FEV1, so forced expiratory volume in 1 second, to their FVC, their forced vital capacity. So you can see we breathe out as much air as we can. So in 1 second, we get about 80% of our air out, and then we still get additional about 20% of air out. And then let's say our forced vital capacity here is 5 liters, let's say. So we got about 4 liters of that 5 out in the first second. So that's an FEV1 to FVC ratio, and normal is 0.8. Now, if you want to tell the difference between obstructive lung disease like emphysema, chronic bronchitis, asthma, compared to a restrictive disease like interstitial lung disease, like something due to sarcoidosis, What's the difference? How can you tell the difference? Well, this ratio. So with obstructive lung diseases, I always say obstructive lung disease is hard to get the air out. Restrictive lung disease is hard to get the air in. So something like COPD, people breathe in, go breathe out, and it comes out very slow. It's hard to get out. So that first second, they don't get a whole lot of air out, and it takes a lot longer to get up to their forced vital capacity. Since restrictive lung disease, they can't get air in the first place, so they're going to have a lower FVC, obviously, but they're going to have most of the air out in a second because just comes out, and there's not a whole lot more to get out, okay? Because we can't get air into the lungs in the first place. So a normal FEV1 to FVC would be about 0.8, obstructive, less than 0.8, so 0.5, 0.6, and restrictive would be greater than 0.8, so something like 0.9, okay? So that's ventilation, and this is how we would kind of check it with a very basic pulmonary function test. Now up here, respiration. So respiration is about gas exchange, and we've talked about tissue respiration, so gas exchange of the tissues. So in the lung, we've got the alveoli. So this right here is an alveolus. So air comes in, and the pressure of CO2 in the air is about 40, and O2 is about 104, okay? That's the alveolar air. So in the venous blood, so this is coming from the pulmonary arteries from the right ventricle, so this is deoxygenated blood, so CO2 about 45 millimeters of mercury, O2 about 40 millimeters of mercury. So we know gases move by simple diffusion, so obviously if the CO2 in the blood is 45, the CO2 in the alveolar air is 40, well, it's going to move in this direction. CO2 is going to leave the blood for the alveolar air. That's what we want. If the O2 is 40 in the blood and 104 in the alveolar air, well, O2 is going to move from the air to the blood. Very simple. That's gas exchange. That happens to these type 1 cells in the alveolus. The type 2 cells release surfactant, this real thin layer of fluid that creates surface tension and keeps the alveolus from collapsing due to pressure changes. And then in the arterial blood, our CO2 is about 40, our PO2 is about 104 to start. Now we know there's ranges, obviously arterial blood gases, we've done ABGs before, so that gives us a pH, a PaCO2, so partial pressure of CO2, bicarb PaO2, so partial pressure oxygen, and O2 saturation, and we know these are the ranges, okay? Obviously we look at pH, CO2, and bicarb to do our acid-base calculations, and then we also have our two values for oxygenation, our PaO2 and our O2 saturation, so we know there's variations. That's respiration, okay? Then here, lastly, talking about our calculations, we need to know some minute ventilation, and we're comparing that to cardiac output. So minute ventilation is basically the cardiac output of the lungs, but nothing to do with cardiac or blood. It's volumes of air. So minute ventilation is breathing rate, how many times you breathe in a minute, and tidal volume. So our average respiratory rate, you could say 12 to 16, 12 to 20, and then your tidal volume, 350 milliliters. So obviously on those basic graphs, tidal volume is usually about 500 milliliters at rest, but we know only about, 70% of that gets down to the alveolar air, so really our alveolar tidal volume is 350 milliliters, because if that air gets into our airways but doesn't reach the alveoli, well, it's not going to be there for gas exchange. So 12 times 350, we'll just say 4,000 milliliters or 4 liters. We know cardiac output, heart rate times stroke volume. Let's say heart rate is 70, and our stroke volume at rest, say 70 milliliters. That gives us roughly 5,000 milliliters. So the point I'm getting at is this last thing, it's our ventilation to perfusion ratio, so VQ. So V stands for ventilation, minute ventilation. Q doesn't stand for cardiac output. Q generally stands for perfusion, but the blood getting to the lungs is roughly the same as leaving the heart. So we could say 4 liters ventilation of air and 5 liters perfusion of blood, and that ratio should always be about 0.8, okay? So that's an important number to understand. So when someone has something like right lower lobe pneumonia, right? So it's filled up with fluid, there's edema there, we're not, respiration is not going to occur there because we're not getting air, there's pulmonary edema. So what your lungs can do, and the blood vessels, I should say, can divert blood other places. So if you're oxygenating fine and having respiration in the upper and middle lobes, well, we can divert more blood flow there and less blood flow there. So this ventilation perfusion matching is very important in the lungs. We know the cardiovascular system and the respiratory system work hand in hand and have to be functioning together.